We've got quite a few students who are logged on today from various institutions, UNCW, UMKC, students from around other places. There's a contingent of University of West Florida students. Our treasurer, Jocelyn Evans, is from University of West Florida. So welcome to the students. So thanks everyone, and welcome to the Southwestern Political Science Association virtual panel series. I'm Jennifer Horan, Associate Professor of Political Science at the University of North Carolina, Wilmington, and the current president of the Southwestern Political Science Association. This panel series was conceived when the association was forced to cancel its annual conference due to COVID-19, and because despite the cancellation, we wanted a way to continue to engage with our colleagues and students. To that end, there's a small group of us who got together to plan this 4-part lecture series. Most of the protagonists with the effort are here with us today. Some had to step away. Dr. Beth Vonamy is our program chair this year with the Southwest. She's Associate Professor of Political Science and Associate Dean of the College of Arts and Sciences at the University of Missouri, Kansas City. She had a provost meeting this morning and so couldn't be with us in person. Deborah Leiter, who is with us in person, is Associate Professor of Political Science at the University of Missouri, Kansas City. And Dr. Tiffany Howard, who is Associate Professor of Political Science and the Director of the Center for Migration, Demography, and Population Studies at the University of Nevada, Las Vegas, is also here. But Dr. Howard has to leave to go get her COVID vaccination. And we thought that that was entirely appropriate. And so her camera is muted right now. So I want to thank all my colleagues who have assisted with this series during the last really 7 months or so, because we did 2 of these in the fall. This is our 3rd of 4 events, and our last roundtable will look at immigration and immigration policy and will occur on March 18th. You can view information about the roundtable on the Eventbrite registration page. So today's topic is COVID, and we're trying to take a comparative approach, a little international perspective, a little domestic US perspective, and some current research efforts on the part of some of our colleagues. So I'm pleased to thank all of our participants today and welcome them. And so I am especially pleased to introduce everyone here. Our distinguished guests are Dr. Wayne Centrone, President of the international non-governmental organization Health Bridges International. Dr. Centrone is a primary care physician, qualitative researcher, and public health professional who has dedicated his career to serving marginalized populations. He is the founder and executive director of Health Bridges International, an NGO focused on serving the diverse health needs of marginalized families, youth, and young adults in the developing world. In addition to his global health work, Dr. Centrone is also a senior health advisor with the Center for Social Innovation, a Boston-based policy and research think tank dedicated to developing sustainable solutions to the challenges of healthcare inequalities, poverty, and homelessness. Our next panelist is Dr. Kristen Taylor, Associate Professor of Political Science at Wayne State University. Dr. Taylor is an Associate Professor in the Department of Political Science at Wayne State in Detroit, Michigan. Her research investigates the policy process, focusing events, policy failure and learning, policy narratives, and the politics of hazards and disasters. Dr. Taylor's current research explores the extent to which different sources of information influence how local governments make decisions. Dr. Taylor earned her Bachelor of Arts from Ohio University, her master's degree in community planning from the University of Cincinnati, and her PhD in public administration from NC State University. Our third panelist is Dr. Tom Birkeland, Professor of Public Policy and Associate Dean for Research and Engagement in the College of Humanities and Social Sciences at North Carolina State University. Dr. Birkeland's research is in the public policy process, which is concerned with understanding the conditions under which government policies change. He is the author of 3 books, including After Disaster, Agenda Setting Public Policy, and Focusing Events, which was also the winner of the 2020 Aaron Wildowski Enduring Contribution Award from the Public Policy section of the American Political Science Association. And Lessons of Disaster, Policy Change After Catastrophic Events, and multiple journal articles and reports. In 2006, he served as a program officer at the National Science Foundation, managing the program that is now known as Humans, Disasters, and the Built Environment. He is currently working as part of the Risk and Social Policy Working Group on issues related to the COVID-19 pandemic, along with Dr. Taylor. His doctorate in political science is from the University of Washington, Seattle, and he holds bachelor's and master's degrees from the University of Oregon and Rutgers University. Our last but not least panelist is Dr. Christopher Clark, president of AHN St. Vincent Hospital in Erie, Pennsylvania. Dr. Clark has been president of AHN St. Vincent Hospital since June of 2017. Born at St. Vincent and a lifelong resident of the Erie community, Dr. Clark is a practicing family physician who has served in a number of leadership roles at the hospital over many years, including Senior Vice President of Medical Affairs, Chief Quality Officer, and Director of Medical Education. Active in the profession and his community, Dr. Clark serves on multiple community boards of directors, including Penn State Barron, Erie Catholic Preparatory School, the United Way, VNA of Erie County, and the Erie Downtown Development Corporation, and has been active in fundraising for the Children's Miracle Network, the Sisters of St. Joseph Neighborhood Network, March of Dimes, and the American Heart Association. He is also a past president and board member for the Erie County Medical Society, a member of the Hospital Association of Pennsylvania, American Academy of Family Physicians, American College of Healthcare Executives, and Pennsylvania Medical Society. He earned his undergraduate degree from Boston College, a medical degree from the Philadelphia College of Osteopathic Medicine, and completed his residency at Geisinger Medical Center in Danville, Pennsylvania. Dr. Clark also received a Master of Health Administration degree from Pennsylvania State University and a graduate certificate in gerontology from Gannon University. A big thank you and warm welcome to all of our panelists, virtual applause, and Haran in-person applause. So one brief note on our format for everyone, for our audience members. I will pose questions to the panelists. He or she will respond. We will then ask the other panelists if they have any questions or clarifications. As the audience members have questions, we're going to ask you all to put those questions into the Q&A. We will monitor the Q&A, and then after we have gone through our set of questions with the panelists, we will ask your questions, and this should be around 4 p.m. All right, so if everyone's ready, we're going to start with Dr. Centrone. Dr. Centrone, as we begin, can you first orient us to the World Health Organization and its approach that it has taken to the global pandemic and the efficacy of this approach?
Well, thank you, Dr. And thanks for allowing me to participate with this great panel. The World Health Organization, it's a specialized agency of the United Nations. And by virtue of its name, health, its primary role is to be an advocate for health around the world. Now, its role globally has ventured in a variety of different directions, including advocating for universal health care, monitoring public health outbreaks and conditions, setting health standards and guidelines. And in recent years, a lot of the work of the WHO, the World Health Organization, has shifted to emphasis on non-communicable diseases, those sort of diseases of Westernitis, cardiovascular disease, endocrinological disorders, the diseases associated with what we now describe excess. But what we're facing right now is a completely different phenomenon. And the World Health Organization has lots of great experience venturing in this intersectionality, these worlds in between. As many of us are aware, in recent times, the WHO has come under great praise and stress for its work in Western Africa with Ebola, and now most notably around the work with SARS-CoV-2 and the COVID-19 outbreaks. It's important to remember, though, that the WHO works in a decentralized manner. The actions of the WHO are geographically distributed, and those are through the geographic entities that exist for the WHO. As a, for example, in Latin America, that's the Pan American Health Organization. In Sub-Saharan Africa, that's the African region. And so each of these regional entities represent the WHO in action within that geographic precept. The WHO has a lot of work in advocating, but not a lot of direct impact in terms of how care is delivered. And that's the great challenge. It's all well and good to ring your bell, but if the ringing of the bell doesn't create action, then it's really challenging to take these great philosophical approaches to managing chronic disease, ending global outbreaks, and regionalizing them down to where local governments can effectively mobilize resources. And so what we've seen around the world is this great disconnect becoming more and more apparent. Truly, the greatest challenge for SARS-CoV-2, the COVID-19 pandemic, is one of local initiatives. And many local areas around the world in the lower and middle income parts of this great planet of ours are struggling to mobilize personal protective equipment, to come up with the resources for treatment, hospital beds, ICU capacity. And I'm not even getting into the whole issues associated with universal vaccine. So the WHO, what it plays is an alarm sounder. And what's happened is that alarm has been sounded loud and clear, and we've not figured out how to take that alarm and make it into manageable, actionable activities that are reproducible around the world.
Fascinating. Well, thank you. So I'm going to go around for introductory questions for everyone before we come back to that. Dr. Taylor, you and Dr. Birkeland are part of a multidisciplinary team studying the COVID situation in the United States. Your team is in the fourth wave of the survey, as I understand it. Can you give us a high-level overview of the project?
Absolutely. And I'd like to thank you, Jennifer, for having me today to talk about our project. So I'm part of a group of scholars. We call ourselves the Risk and Social Policy Working Group. Our collaboration together of political scientists like Tom and I, our collaborator, Rob DeLeo at Bentley University, Desiree Crowe, Betsy Albright, Liz Shanahan, plus people in public health like Katie Dickinson and Courtney Welton Mitchell. We are interested in the intersection of COVID, the policies that are put in place by state and local governments, and then the risk mitigating behaviors that people take to protect themselves from COVID. So we're really interested in the intersection of those three areas of research. So far, we have three sort of strands of research. One where we're looking at the messaging around COVID and what types of messages about risk mitigation are memorable to the general public. And so we've deployed a survey to 6 states. That was phase 1 of our project. Phase 2 of our project is to look at vaccine hesitancy. And we've just completed the first of a series of national surveys of public opinion about risk perception, politics, political ideology, and their people's vaccine hesitancy and hesitancy rates in the United States. So messaging around COVID-19 is one piece of what we've looked at. We have another piece of our group that has looked at racial disparities in COVID rates, in COVID infection rates. We have a piece of work that Tom and our collaborator Rob and I have worked on looking at the effects of federalism on the COVID-19 response in the United States. And so a lot of the challenges that Wayne was talking about access to PPE and a lot of the necessary procedures that need to take place down the line from the WHO all the way down to local communities. It rings true in the United States too. So we've really done a lot to examine the clarity of policy decisions at the federal government and how they have, or the lack of clarity in policy decisions at the federal government and how they have had ripple effects across the states. And then we've also looked at the politics of COVID-19 as what we call a focusing event that shapes policy agendas. So that's another piece of our research. I think that's it. Our group is very active. So we have, so there's a group that's studying mask wearing and risk mitigation behavior around mask wearing that looks at racial disparities about who wears masks and who doesn't, and looking at some of the politics around that. So we're a pretty big and active research group. And in terms of, for political science and for social science, we're really taking on this team science approach that's common in other disciplines, but we're really trying to take the tiger by the tail in terms of how we address and collaborate around this particular issue. So, and we've done our survey research, but we've also done qualitative research and content analysis. We're doing web scraping and auto coding and machine learning of policy documents. So we're really methodologically, we're casting a pretty wide net.
Amazing.
Yeah.
It sounds very exciting. And we will try and post the URL to the research group webpage in the Q&A for folks.
Yeah, I can.
Or yes. Okay, great. Dr. Birkeland, can you talk to us a little bit about what you've been discovering as the project has moved from phase to phase? Maybe there's a super interesting change in the data to date. And I had been wondering when I was looking at the webpage and reading through one of the technical reports, whether or not respondents became more proactive about perhaps mask wearing, personal protective actions of some sort, or maybe perhaps the level of concern about COVID had changed in some significant way. Could you talk to that for us, please?
Yeah, and I'll preface that by saying that this is kind of the raw material that people who study the public policy process like me use when we're trying to understand policy responses. It's not common for someone who does what I do to look at individual level data, public opinion data about behaviors. We tend to look more at the institutional responses to these phenomena. But the precursor to that, of course, is understanding, what people are doing, how they understand this problem. And so, for example, the question that always arises, it seems, is what about mask wearing? Early on in the pandemic, there was some mixed messaging about mask wearing. It sounded like at the beginning, it was like, well, you probably shouldn't be trying to rush out and get a mask because supplies are limited and we've got to be careful. But then the increase in mask wearing of stated intentions to use masks has been really impressive. Most people, most of the time, say they are going to use a mask, and we have some data that suggests that it's Democrats and Republicans alike, somewhere between a thin majority and a significant majority, say that most of the time when they're with other people outside the home, they're wearing a mask, well into the 80% range. But they also we've really found some really interesting countercurrents in the data. We found that 46% of the wave three of our wave 3 study respondents said they plan to gather with people outside their household for Thanksgiving. But 86% of these respondents indicated that they'll take precautionary measures. And they may have had every intention of doing that, but it didn't always work. And so what's interesting is that people were told that these gatherings were risky, and yet we had a large number of people attending these things. One of the interesting aspects of our data is also that people fear contracting serious COVID out of proportion to its actual incidence in the community. Well into the 20% plus range of people say they fear catching COVID. And yet that's not quite the rate. And the rate of severe COVID, of course, is somewhat less than that. So we have this kind of countercurrent in which you have people saying, yes, I'm concerned about catching COVID, but you also had a larger than desirable number of people saying that they were willing to join a gathering outside their immediate household after during the holidays. So individual behaviors aren't really internally consistent across our data set, and I'm trying to sort of tease that over time. One question is, whether or not mask wearing has increased because people are learning about masks. And this is something I'm very interested in, what we call policy learning. But and the data there are, I think, a little bit hard to parse because it's not clear to me whether people are wearing masks more because they've learned about the value and importance of it, or it's just because it's a social norm that's being enforced by businesses requiring people wear masks, or by people that have a high degree of respect, like Dr. Fauci saying we should wear a mask. In a world in which Dr. Fauci's approval ratings are probably about twice that of Donald Trump's, and Dr. Fauci says wear a mask, you would probably not be surprised to see relatively high levels of mask use. So those are some of the interesting things we've found so far. It's still early days, so we've got a lot more work to do.
Fascinating. So next question is for Dr. Clark. As a hospital director, what's the most important lesson learned for you and your team? And can you give us a high-level overview of hospital responses in general, or maybe the situation in Pennsylvania? And in particular, because I stumbled onto Dr. Clark giving a press conference in Pennsylvania, I was interested to know, how has working with local government officials worked in your state?
Yeah, Dr. Brand, thank you for inviting me to this panel and this discussion. And I'm going to give my perspective, as we've been living it for the last year. It's real world. We are a 350 bed hospital in northwestern Pennsylvania. Erie is the fourth largest city in the Commonwealth. When this started just about a year ago, we're coming up on an anniversary, an important milestone of when we put our command center together and implemented our emergency operations plan as a result of what was going on on the East Coast and in Europe. But essentially, it's been a roller coaster ride, starting initially with a lot of intensive planning. We didn't have patients until April, but for almost 2 months, we were preparing immensely for a surge, that which we were witnessing on national news. We didn't know when it was coming, but our initial efforts were preparing for so much uncertainty, handling an onslaught of patients more than what we were typically able to handle or typically seeing. So our focus was on safety, educating, creating staffing plans or surge plans, making modifications in our facility for separate areas of the hospital that we could take care of COVID patients, making the necessary changes for respiratory isolation, specifically creating negative air pressure rooms, making sure that we had adequate PPE. That was an initial concern of ours. Are we going to have enough supplies for our staff to keep them safe? And then testing. Testing was an enormous stress on health systems. Initially, when we were starting to investigate whether someone had COVID, it would take 4 or 5 days for a test to come back. And of course, if someone's hospitalized for their condition, we treated them as if they had COVID initially. So all of the necessary precautions were put in place. So we initially saw very few COVID patients, and we know that there were pockets of outbreaks across the country. We had our ups and downs and managed fine with all kinds of lessons learned. But really, it got most intense around that Thanksgiving timeframe when the guards were let down. There's a lot of reasons, but suffice it to say is because people were moving indoors where they're getting together in small gatherings, but albeit it was a nidus for spread of the infection. And we had our spike, much like occurred in other areas of the country, in December and into early January, where pretty close to 30% of our inpatient census was COVID patients. that equated to having 4 separate areas of the hospital that had to be completely separate from where we kept COVID patients completely separate from everybody else. So there's been all kinds of lessons learned. And the one thing I'm most proud of as it relates to your question is that we've learned a lot about teamwork. And clearly there's been an incredible amount of education and people learning to work in each other's areas. Outpatient nurses were coming in to work in the hospital. Doctors that were typically outpatient would be coming in. And ICU nurses were teaching medical surgical nurses how to raise that level of care for our patients. So they're experiences that we will never forget. And I think as a health care provider, in our neck of the woods, I think we're able to apply the lessons learned to do a better job to taking care of our patients for this foreseeable future. I think it's something we will never ever forget. And then your question about the partnerships, we absolutely in our neck of the woods, I think there's benefits of being a big small community. We do have a sizable public health department up here. It's not as big as the larger cities of Pennsylvania, like Pittsburgh and Philadelphia. But we were able to partner with local government officials in a very productive way. The health systems in this community actually came together to collaborate. We didn't end up executing on sharing resources as much as learning from each other how we were handling things. And there was a lot of benefit in working together, even with competitive health systems. But our partnership with the Erie County government and the Department of Health locally, I think is something I'm very, very proud of. I wish they had support from our state government, but at the same time, we at least benefited in collaborating with them. And then, of course, it's translated into the work that we're doing together on vaccinations, which I know we'll get to as a part of this panel discussion.
Excellent. Thank you for that. It's so fascinating. Dr. Centrone, turning back to you for a minute, I think when we're thinking about the research that Drs. Berkland and Taylor are doing and the experiences that Dr. Clark is having, you and I had a conversation earlier in the month about domestic culture and local expectations impact, spread of disease, transmission of disease, and also case loss and the variation in fatality rates. Could you speak to that a little bit from your perspective?
Yeah, thank you. I'm reminded of a quote from Patrick Geddes. He said that the key to global health was to think globally and act locally. And that sounds great in precept. The execution is quite challenging because so much of local action is driven by local culture. And what we found as we started this conversation by saying is that as many mandates as you want to declare out of Geneva, the reality is that they look different in how they're actionable in Bogota, and even more different in how they're actionable in Huayabamba in the Sacred Valley of Cusco. So these local manifestations have made it very challenging. And that's partly driven by the constantly anastomosing influence of culture. In the United States in January, we had one person die from COVID every 28 seconds. In fact, in January, COVID became the leading cause of death in the United States. Now, lest we think, oh, well, that's a disease of the aged or those who are burdened by comorbidity. A recent study by Yale and Harvard actually found that COVID has now surpassed, for patients who are in the age group of 25 to 44, overdose as the primary cause of death for that age group. We are literally watching a sea change in health. And yet we have people who will clamor to tell us there really isn't, that this isn't really something, that there is an overreaction, that it's nothing more than the flu. And that cultural nuance, the way that that plays out in social circles, is very challenging from a public health perspective to address, because it ultimately means that messaging needs to be different in different ways to different populations. That's really challenging for public health professionals who think at the population level rather than down to the level of the individual. I think so much of what's happening in a country like Peru in Latin America is there's a fracturing from federal to local government structures. Peru, as a for example, had a Peruvian president replaced right at the very core of what was going on in the second wave. The impeachment led toward the resignation, but when they lost the president, essentially their government system started to dismantle. Now, 5 ministers of health later, and they still don't have a consolidated plan for addressing COVID and SARS-CoV-2 in the country. And so that means that they've been pushed to the bottom of the list and able to get access to vaccine. That means that right now they currently only have 1 million doses in a country of 32 million people. So each one of these things are wrapped in so much nuance that's ultimately driven by culture.
I knew it was bad in Peru, and thank you, Wayne, for making me feel really bad for them. My students, just as an aside, were following the political disarray this past spring. So, Dr. Taylor, thinking about risk perception of U.S. Citizens, I think it's related, and I'm beginning to wonder, how different any individuals are, right? Despite cultural differences on this. Can you talk to us about risk perception of U.S. citizens? As Dr. Birkeland had said earlier, one of your early findings is that risk perception of being able to contract COVID seemed to be something that people were over perceiving. Do you have a hypothesis or anything sort of starting to emerge from the data about why that might be the case? And what the relationship of that risk perception to perhaps taking these other proactive protective measures might be?
So one of the working hypotheses that we have is that people are assessing their risk and the risk of getting COVID in ways that either pose it as a personal gain to them by taking on personal protective behavior like mask wearing, social distancing, or that it's a loss by not taking on these types of behaviors, that they will feel the effects of COVID more dramatically. And so people use these, our hypothesis is that people use these filters about gains that come by addressing your personal risk and by taking on, wearing masks, staying away from people, avoiding crowds, social distancing, not going to bars and restaurants, things like that. Or that they view their risk of COVID as a way of preventing loss. I'm going to wear a mask and wash my hands and stay away because I want to avoid contracting COVID because I'm so afraid of it, because it's so fearful. So that's we're sort of working through a data analysis on that piece of it now. People in some of our wave 1 and wave 2 surveys, people were just as afraid of or thought that their risk of getting COVID was just as likely as their risk of losing their job or running out of money. So we can talk about risk perception, but there are cuts to how that varies based on race, based on class, based on socioeconomic status, based on exposure. So we're trying to understand how that plays out. We have, one of the big themes that has come out of our work is that there are racial disparities in how people are disproportionately affected. People of color are disproportionately affected by COVID compared to Caucasians. And that has really been a part of the politics of this pandemic that we've been trying to understand. How does that intersection of race, disparities and risk perception come together? And some of our data that's come out of the 5th wave, or the national survey about vaccine hesitancy, demonstrates that people who are white would, like 65% of people who are white report that they would go get the vaccine today if they could, whereas people who are African American say that if they could get the vaccine today, only 35% of them would. And 38% of them say that no, they wouldn't, and 20% are unsure. And then there are differences in that, because Hispanics, 45% of the people we surveyed indicated that they would go get the vaccine today. 27% of them said that they wouldn't, and 17% of them indicated that they were unsure. So we have perceived risk of getting COVID playing out in different ways as we move towards vaccinations and vaccine hesitancy.
So I two things that occur to me about that is I wonder if it's about your network size, and also clearly different minority groups in the United States have different, political histories in the United States. So I could see those as important sort of related hypotheses about this.
Yeah, we do. I think that we'll talk about this a bit later, but we have some public trust data about which types of people and which specific people our respondents trust more than others, but I don't want to get ahead of the agenda here.
Thank you. Dr. Berkland, can you talk to us a little bit about changes in how subjects responded to certain questions might be related to learning about COVID? One of the things we like to think as educators is that the more you know about things, the more equipped you are to respond to problems. So when I was reading the report, I noted that there were differences in mask wearing between the first and the second waves. Maybe you could just speak to that about, what have we learned and maybe what's being reflected in your study. Dr. Berkland, we have.
Yep, here, I'm back. Sorry, for some reason I was muted. I'm not yet persuaded that there was learning going on in the change in mask wearing behaviors as much as there was norming. And now there's probably, those are probably like vectors, right? I mean, there's probably some norming and some learning, and they probably interact in some ways. And I haven't delved into that, but I'm suspecting that with, especially with the change in administration, we don't have a lot of data on this yet, I don't think, but the change in administration and the messaging coming from President Biden, who won the last election, just so that we're all clear, he did in fact win the last election. And most Americans voted for him, and most Americans think that you should wear a mask. So, taken all together, there's some really interesting data about mask wearing. And, one of the questions we had in wave 3 was, how often do you wear a mask? And 82% of people say they always wear one outside the home. 82%, right? They're not wearing it everywhere. If they're outside walking, the people that say they wear it is 26%. But you can see where people are starting to shape their behavior around masks based on what they consider to be, I think, a broad social risk. In other words, it's riskier to not be masked indoors than it is outdoors. But the reason I'm not sure there's much of a learning effect is this goes back to the question about why do people perceive the risk of catching COVID, and the data we had is that 29% of our people thought that they were going to contract COVID, which is a rate higher than that of the general population. Of those, 34% thought that they were going to become seriously ill, and 21% thought they were likely to die. And the question is, why is that? Why are we seeing those sort of numbers? And I don't have any evidence on this yet. It's too early days, but I think the dynamic is similar to that of people's belief in their likelihood of being victimized by criminals. During the 1990s in the United States, the crime rate was on a secular downward trend in real life. In the world occupied by television journalists, crime was going up, measured by the amount of time devoted to to crime stories on local television news. If it bleeds, it leads, right? And so the data from back then showed that the more television news you consumed, the more likely you were to believe you were going to be a victim of some sort of crime, right? Out of proportion to its actual rate. Now, think about the saturation of the news media with COVID news, right? And that might help explain why people have a heightened sense of risk. What I find puzzling about this, and which deserves further analysis, is given these rates of belief that you're likely to get seriously ill or maybe die, why are there some, a not insubstantial number of people who are unwilling to take certain protective measures like mask wearing? Or why are people clamoring to open up businesses and things like that that would pose greater risks than if they weren't opened up? So those are some interesting things I think we've found.
Interesting. That's a lot of dissonance, right?
Yeah. Well, and we know that people in political, in decision making, in policy decision making or in other decision making, are not perfectly rational actors, right? In other words, if you prefer, to do thing B over thing A, and you prefer to do thing C over B, then you ask somebody, do you prefer to do C over A? Sometimes people will say A, even though, logically, that wouldn't hold, right? It's non-transitive is what we call it. That's not a knock on people. When I say that people aren't behaving rationally, it means that people are behaving. People use shortcuts, heuristics, rules of thumb. We're all, subject to cognitive biases. Some of the people that are best at harnessing cognitive biases without knowing they do it are college professors, because we're really good at gathering the information we want to see versus what might be the sort of the quote unquote real story. So by saying that people are not rational actors, it's not a knock on individual behavior. It's a reflection of the complexity of the kinds of decisions that people are trying to make in this pandemic, and these are hard decisions. They're very tough.
Thank you. Let's turn back to our Dr. Clark, our person on the sort of hospital front lines. Can you tell us a little bit about what you know about the different methods and rationales behind all the different approaches that have been utilized for vaccine distribution? Because I know, for example, Mom went to St. Vincent's and got her vaccine from St. Vincent's. And so, but here in New Hanover County, and we're doing it from the health department. The hospital is not administering yet, but they're ready to. So could you talk to us about that?
Yeah, I certainly can speak to my own experience here, and I know more about what Pennsylvania is doing compared to other states. I certainly have reviewed a little bit about what's reported mostly through the CDC about the other states' performance. But generally, suffice it to say, it's been such a complicated process and not done perfectly by any means. Operation Warp Speed was successful with production, but not distribution, clearly. It comes down to, it follows the basic elements of supply and demand, and there's just way too much demand out there compared to the supply that's available. And when you have scenarios like that, and what we're living through is trying to get access to the vaccine to either fall under two categories: protect the vulnerable, those that are at greatest risk if they have COVID. We know that it correlates with age, but quite frankly, age is not the only factor. We've seen so many people that weren't with advanced age succumb to COVID because of other conditions, notably obesity, lung disease, diabetes really stands out with COVID for whatever reason. The vaccination process should protect the vulnerable, however they're defined. Advanced age is definitely there, or preserve workforces. And that's been the approach. So the CDC, sort of started the script to promote that distribution and administration of vaccine should target healthcare workers because that addresses the preservation of the workforce. We know that we need a healthy workforce to take care of patients with COVID or even others without COVID. And then the other category of protecting the vulnerable, where it started, is to get access to the vaccine to those in nursing homes. We know that a significant percentage of people succumbed from COVID that had ties to nursing homes in a post-acute care settings. So that's been the strategy where every state started. And then there's tons of deviation from there. We were very successful in our network to have at least 80% of our workforce get vaccinated. And we did that in a number of weeks. The Pfizer vaccine came out first, as everybody knows. A week later, Moderna. We use Pfizer here at AHN St. Vincent. And we were able to successfully go through a process to get our workforce access to the vaccine. In Pennsylvania, the nursing home population was actually addressed by contracts that were made with national retail pharmacies like Walgreens and CVS. So hospitals were not a part of that. So each state has had its own modifications and approaches to helping those that they give supply to do the risk stratification. And again, I can speak to the Pennsylvania experience the most. After they asked us as a provider to administer vaccine to healthcare workers, they then asked us to address EMS staff and independent healthcare workers, people that are sort of out there providing healthcare, like dentists and home health nurses. They asked hospitals to get involved with that. But as time has gone on, it's gotten more and more more and more difficult, And going back to the just basic elements of supply and demand, there's been increasing demand with not enough supply and not enough providers as well. So I know the stories are a bit different, but common themes in other states. It has created quite a challenge. And there's, as much as we like to celebrate our successes with as many people that we've vaccinated, we've given over 13,000 doses of the Pfizer product here at AHN St. Vincent. Our network has given over 70,000 doses. But when you look at Pennsylvania, we're 47th in the United States in the percentage of doses administered compared to what's been received. So that equates to about 68% of the doses have been administered compared to what's been received. Best practice out there is New Mexico, by the way, that's pretty close to 100%. So, there's states that are doing it better. I think things are improving, but at the same time, it's been, a great challenge on those that were, sort of asked to be a part of this process. We're proud to be doing what we're doing, but we're just not able to do it fast enough. The other thing I'll throw out there, because it does relate to going back to how we partnered with our local government, and I should have said this the first time, but we are proud to have partnered with our local government to do testing. We actually do testing out at community centers, a great source to get access to the marginalized populations. So we've piggybacked that work to get vaccine access to minority groups in this region that way. So and this is something I'm so proud of as an example. We have done a job of reaching out to people through electronic health record to get them scheduled, but there's so many that don't have that same access that others do. So through the community center relationships, we've actually done a sort of a grassroots effort to get even all the way cascading down to the local neighborhoods and local churches, getting church leaders to identify vulnerable people based on age, based on condition, and then even doing manual scheduling of people in an electronic world in order to get access. It's not enough compared to what needs to be done and compared to what the demand is out there, but it's at least efforts recognizing, what people's challenges are in getting access to the vaccine in a world that's, built on, an electronic structure.
Oh, amazing. Thank you for telling us about that. Very interesting. Dr. Centrone, can you talk to us a little bit about, so Dr. Clark's just told us about the challenges and all the sort of really innovative kind of ways they have had to employ in order to respond to COVID here and the responsibilities placed on them. Can you talk to us and the audience about the additional challenges that communities in other countries around the world are experiencing when they have to layer on to this pandemic existing problems, as in Peru, for example, with corruption and government instability?
It's interesting. I think what we're looking at right now is a systemic challenge that's complicated by personal trauma, by the trauma of the individual. Dr. Birkeland said something that really struck me, and forgive me, Dr. Birkeland, I'm going to paraphrase you, so I hope I get it somewhat correct here. And that's that, there's really, it's a challenge to find the rational actor in this situation, because it's a reflection of the kind of complexity that people are trying to master in really challenging circumstances and situations. And this is biologically wired. About 25 years ago, we learned the biggest little secret in the world. And that's that trauma is the norm and not the exception. A quarter of children before they start their first year of school, and this is generalizable data to many countries in the world, a quarter of children will have a trauma experience before their first year of school. And that complexity, that trauma gets higher and higher as we get older and older. In fact, as adults, about 60% of us have had an adverse childhood experience, trauma in our life. Now, look, that's below the surface. That's the iceberg that we can't see, this universalism of people living in trauma. Now take the developing and middle income world where people on a daily basis are struggling to meet their needs. Poverty is a traumatizing experience. And so people are living through hypothalamic pituitary adrenal overload. They're literally on stress hormone overload at baseline. Add into that a global pandemic where your ability to find economic resource to serve for your family is limited, where the government in many ways is limiting your ability to be a caretaker and interfering with your ability to engage in the lifestyle that you want. And no wonder there's so many challenges. We're at a great social awakening of sorts. And this is to be expected because there is so much trauma in our world. And because this pandemic has literally poked the dragon, we're now looking at the clashes and how this has to do with politics and sound bureaucracy is that in countries like a Peru, like a Colombia, like many places in sub-Saharan Africa, without well-functioning person-first governments, those are re-traumatizing people. Those are actually vicariously traumatizing to people who live in those environments. And that means that the government itself is not contributing to a treatment. It's contributing to the cause. So it's so complex because of the baseline of trauma that exists, because of the way that we're biologically wired. We are biologically wired for relationship. Dr. Clark said one of the great things that he's seen is his staff has come together to be champions of teamwork. That makes total sense. Our brains are wired for teamwork. We have mirror neurons that are nourished by being in a relationship with others. But yet, what have we done? All of our non-pharmaceutical interventions are oriented around physical distancing, mask wearing, obliterating our ability to create connection through emotion. And yet, so many of us are on a hair trigger. We are literally a fight or flight away from so many terrible things. So this system that we're existing in, it's complex because of the baseline of what's there. And I'm fearful that we're looking at the tip of the iceberg, that we know for a fact that mental illness, mental health conditions, untreated substance use disorder leads toward more stress, and more stress leads toward more chronic disease. So where will we be in 10 years? Through this 18 months of stressful experience on top of decades of inequality and inequity.
So the challenges are pretty immense here. Dr. Taylor, I think this is actually a good segue into the political trust kind of questions that I was going to ask Dr. Taylor next. So considering what Wayne has just said, Dr. Taylor, do you want to talk to us about the part of the research findings where respondents are indicating whether or not they think the state should be more or less restrictive, and how this relates to the political trust question? As Dr. Birkeland mentioned early, thinking about the high levels of trust that Dr. Fauci seems to inspire compared to former President Trump. Can you contextualize that for us?
Sure. So to build on what Dr. Centron had talked about trauma, when we think about politics and American politics and public perception and public trust in government, we are really, in the last 4 years, in the time leading up to the start of the pandemic, we have been through this really unusual political set of circumstances, right? Things that were, regardless of whether you're a Democrat or Republican, in every stretch of the imagination, American politics have been outside of the norm of every single thing that we have experienced. We impeached a president twice, that's unheard of. We had people rioting and protesting who stormed the Capitol. So to think about the politics of the pandemic and public trust in government, to set that within the broader context, we had 4 years leading up to this of great political upheaval. And depending on how you view it, we operated under a lot of uncertainty. And for some people, that could have been very traumatizing. So set COVID-19, the pandemic, within that context, we go into this with public trust in government. Well, in the United States, generally we have high public trust in government. We don't think government is going to be out there to do us harm, but we are mistrustful. We are skeptical because we are an anti-statist country, right? We don't like too much government, just regardless of whether you're really progressive or you're really conservative, right? That's who we are as Americans. But in the context of COVID-19, and information that was coming out of the federal government, particularly around, or information that was coming out about COVID-19 vaccines, our research shows that that public trust in Donald Trump, when he was president, as a source of information about vaccines was really low, right? We had 25% of white Americans in our study who found him to be trustworthy, 19% of Hispanics, 8% of African Americans, 10% of Asians found him to be trustworthy. In contrast, Anthony Fauci, 59% of white people found him to be trustworthy. About the vaccine, we found that 50% of Hispanics found him to be trustworthy. 59% of African Americans found him to be trustworthy. Scientists had even higher public trust. So we put a lot of faith in science and what scientists told us about the disease and about the vaccine. So 69% of whites, 59% of Hispanics, 60% of African Americans, 65% of Asians found scientists to be trustworthy about the vaccine. So, and Joe Biden, he was trusted more than Trump, but less than Fauci. So 45% of whites found him to be they trusted him to provide accurate information about the vaccines. 44% of Hispanics found him to be trustworthy. 56% of African Americans found him to be trustworthy, and 38% of Asians. So when we think about personal protective behaviors and vaccine hesitancy, and as Wayne kind of talked about this this issue of like local preferences and local culture and local trauma, particularly in areas that have high degrees of poverty, really shaping our response to the pandemic. We could hypothesize that that racial divisions in the country shape our perceptions about the trustworthiness of the vaccine, and that's just another layer of context, of social context to put on the pandemic as we think about moving forward and trying to get everyone vaccinated.
Fascinating. So I want to ask sort of a summary question of Dr. Birkeland and Taylor, because we're at the 4 o'clock and we want to have some time for audience question and answer. So I had 2 other questions for you all on here about dissatisfaction with local school districts and whether or not risk perception is helping the United States with COVID. And I think to the extent that risk perception has already been addressed a little bit here, and you're trying to figure out what's going on still in the research, is there something else in particular that you think is really telling about what you're finding in the panel survey that you'd like to address with us in a summary form?
Tom?
Well, I think that the 30,000-foot view is that the extent of divisions in the country and the extent to which various normal protective behaviors exist and that people follow them, I think the story is better than you might assume in the news media and that you might hear in various circles. For example, I think our data have reflected, I know data from other sources have shown that vaccine hesitancy overall is declining, particularly as we put the prior regime in our rearview mirror, because the belief in the quality and safety of the vaccine was heavily bounded up in trust with the prior administration. So you're starting to see, and so what we're seeing is this kind of perverse situation in the United States in which you have news coverage about A, people being vaccine hesitant, and B, people trying to jump the queue to get vaccinated, right? Now, there's no reason why both can't be happening at the same time, but it's not just one thing, and I think that's really important. Our last Wave 3 report showed that over time, mask wearing increased in every state we surveyed. Now, there were state-by-state differences. Some states had lower prevalence of mask wearing than others, but the differences weren't great. For example, the people saying they always wore it indoors in public was as high as 87% in Massachusetts and Colorado, and as low as 75% in Louisiana. But still, it's pretty high, right? And trust in the kind of institutions that you would normally expect to respond to a public health emergency in the United States, state and local government, scientists, the medical profession, is still relatively high. Trust in top level national leadership, not so much. But I think that the message is one of cautious optimism, that most people most of the time will behave in a way that we think is probably the best for them and their communities. What we have to be concerned with, of course, are the people at the margins who occupy a lot of attention and who may have a malign influence on other people doing the right things.
Fascinating. Okay, so back to Dr. Clark then for a final question for you. So with no criticism intended or implied or indicated about any of the way the United States medical community and citizens have managed through all of this, what do you think the sort of the takeaway is about the U.S. problem of having 4% of the global population, but 20% of the global COVID mortality. And maybe this is a U.S. Sort of general question, but I mean, this seems like a troubling statistic, and I'm interested in your thoughts on this.
So having a proportionally higher percentage of mortality, in relationship to other countries. Yeah, I know the intent is not to be critical, but obviously things could have been handled better for sure as it relates to getting ahead of what was necessary to protect one another, to put those safety mechanisms in place to prevent the spread. We know that there was a lot of controversy. I think Tom was talking about that previously. There's a lot of controversy about the expectations. There's mixed messages out there about the benefits of wearing masks. It was even in the healthcare sector. It was a short period of time in retrospect, but we were saying as health experts that we shouldn't wear masks because that was always thought to be previously a nidus for infection, putting you at greater risk. Obviously, that was squelched. So there was, again, a lot of mixed messages. People weren't consistently following the expectations. There was pockets of clear resistance to the measures, pockets across the country of clear resistance to the social distancing measures that were expected. And then the other thing is that we didn't protect our vulnerable. We didn't protect, people at greatest risk. Like I said previously, a significant percentage of people coming from nursing homes succumb to this disease, and more could have been done to protect them, for sure. So that's why we stand out as a country. We were late in some of these areas. And I think there's a lot of good things to promote, as far as what we did from a therapeutics perspective. I think a lot came together in the medical communities, research-based, and subsequently in the healthcare delivery system to offer as much as evidence could dictate the beneficial therapies. I know we had a sidetrack on hydroxychloroquine, which went away, eventually, but at the same time, we came together and there's not tons of evidence to show the benefits of things like the convalescent plasma and the remdesivir, even the monoclonal antibodies, all produced rapidly and put into action very, very quickly in our health systems. That's something that, not necessarily can be done in other health systems across the world. So definitely missteps along the way, lessons learned, lives lost, and that's tragic. At the same time, we did do pretty well, compared to across the country with therapeutics. The other thing I'll mention again is testing. Lots of missteps there. Getting access to testing. I already gave you the example that initially we were waiting 4 or 5 days to get test results. And to get your arms around anyone with public health knowledge knows that you have to have adequate access to do surveillance and identify what you're dealing with as quickly as possible. And the delays in getting access to testing were certainly setbacks that, quite frankly, were hard to get past. I mean, if we had an ideal world of getting our arms around a pandemic as quickly as possible, it's getting the testing for that disease produced and readily available with quick turnaround. And that's how you get your arms around a pandemic really quickly.
Jennifer, can I follow up quickly on what Dr. Clark was saying? If you knew nothing else about it, well, the first thing I wanted to say is this: we don't have one national public health system. We have 50 public health systems, right? And within each state, you've got N public health systems, where N is the number of either public health districts or counties, right? So there's going to be incredible variation within state and between state. The second thing I was going to say then is, since I'm a political scientist, I might as well just come out and say it. If you knew nothing else about a state, other than the party of the governor, you could predict whether or not it's going to have a higher or lower mortality and morbidity rate from COVID. Republican, higher; Democrat, lower overall. Now, if you control for things like population density, that becomes even clearer. It's you've got states like Iowa or South Dakota, where the governor has not only failed to implement effective public health measures to slow the pandemic, but has actually mocked them, has actually cast aspersions on those who would do these things. And that's not been helpful. And I think, at some point there's a normative case to be made here that there is a government performance problem, and it has a very strong positive, a very strong partisan dimension. And it's something we're going to have to confront.
Thank you. So final question for the panelists, Dr. Centrone. When we're talking about all of the known unknowns about managing COVID from a public health perspective, all these different governmental challenges around the world and in the United States, federalism, states, partisanship, all these kinds of things. What do you think's the public health reckoning that needs to happen around the world with the World Health Organization or domestically in other countries like Peru, for example, that needs to happen?
That's a great question. I think the key would be removing the politicization of public health. That public health can't be viewed through any political entity. I mean, this is a big challenge in a country like Peru, where there's so much centralized government, and there's a natural suspicion of government anyway because of the way that society is organized. Society is organized around a class-based system versus perhaps the way we organize ourselves in North America around a race-based system. And so people are naturally suspicious there of government because there's a class structure, and they are suspicious of anyone that's a class above them. And so you have this government who's creating these policies that are public health, but they're coming through the government, the organ of the government. And then there's little to no resource at the local level for enacting them. So you have these great policies, and the local government is left to try and figure out how to sort them out and telling their local citizenry to do things, but not having any means of enforcement or even activities for providing testing or follow-up care resource. And this is particularly true in Peru with the centralization of activities. Lima and Callao, a city of about 16 million people, if you counted the whole area, the vast majority of intensive care unit capacity is in the city of Lima, but yet you have half the population spread out in hundreds of towns all over the country with no ICU capacity whatsoever. So you have this constant tension that exists. And I think if public health could be removed from that tension by depoliticizing it, you'd see that it actually becomes a voice for scientific application of population resource rather than this arm of the government that's trying to manage public health as another entity, another one of the many different capabilities of the government.
Wonderful, thank you. So now we're going to turn our attention to the audience questions. Dr. Leiter's been compiling them in the background. Dr. Leiter, do you want to ask these questions? I can see your list.
I'm happy to ask them, but if you've got the list.
Well, can you choose really quickly what you think the most important ones are for me? I can see the list. Some of them I think they've addressed a little bit. So for example, I don't hear Deborah. She might not be able to come back on. And for anyone on
I'm live streaming, so I'm just muting a couple of things. Yeah, I kind of tried to put them in order of the sort of audience questions, but maybe the first two listed, and then I'll resort from there.
Okay, excellent. All right. So the audience wants to know if we've seen other health issues be so politicized previously in the past. What thoughts about that? Anyone?
I think one need look no further than the HIV epidemic. And,
exactly.
And we can certainly and if we want to, we can go further back and we can talk about Tuskegee. And if we want to, we can go further back and we can talk about the fact that we made venereal disease into this public health moral tragedy versus just recognizing that it was a communicable disease, just like any other disease, just like any other infection. So I think we've had plenty of these, but now we have a media machine that never stops. And it just needs to feed itself by constantly putting more and more news out that's sensationalized.
Okay, I have another question for you all from the audience. We have a question about vaccines being distributed. Why are vaccines being distributed in areas where demand is lower due to vaccine skepticism, whereas in areas with lower skepticism are also not receiving enough vaccine doses to meet demand? Is there something we should consider when we think about vaccine distribution?
I'm going to take it. I've been thinking about this a lot because, and maybe we can talk, if we had time, we'd talk about why don't we just distribute them randomly. I was talking to someone the other day to preface this, that everyone has an opinion now about the way vaccine distribution should work, much the way everyone has an opinion about how airplanes should be loaded and unloaded, right? Nobody likes the boarding system for an airplane. You group it, if you get in group 8 and you can't put your bag in it's like, well, why isn't it just random? Or why am I in group 8? Nobody likes it. Everybody's got a different solution. Load from the back, load from the front, set off a starting pistol and let everyone go. Now, with that in the context, I don't think, and I think our colleagues here who are in health would probably agree that we make the decision on the allocation of healthcare resources based on people's feelings about those resources. And the last thing I'll say about it is vaccination is not, by and large, intended to be an individual benefit to the vaccinated person. It's a method of promoting community health. And so I'm not that concerned about distributing vaccines to communities where there's great deal of vaccine hesitance. I will say, though, that we have to understand that some of those communities might be, for example, the African American community, which the Tuskegee, situation was brought up. There are strong historical reasons why, and empirical reasons why African American people think that they're not treated fairly by the health system. Not limited to that one African American doctor who died of HIV after being poo-pooed in terms of her symptoms by the hospital where she was treated. So it would be a hard thing to do to say we're only going to distribute vaccines to places that are really enthusiastic about it, because that's not the goal. It's not a popularity contest.
Yeah, and I would piggyback on what Tom said, in that the distribution of the vaccines is really it's a function of government, right? It's a public good, right? Having a well-vaccinated public to promote herd immunity is a public good. And that's what government does, right? We don't want Walmart to do that. We don't want, Costco to do that. We want government to do that, to ensure that there is equal access and distribution to the vaccine. The implementation of actually vaccinating people, that's where all of the public health experts who understand their local communities and understand how they can lend credibility and build credibility for the vaccine to people that are reluctant to get it. That's where the magic of public health comes in. So, so vaccine distribution, we need to distribute them fairly and equally. And I'm kind of like Tom, you go when they call your number, and, don't make too much fuss about it. I don't know how to load an airplane either, but the magic of it is getting all the public health experts to understand their community needs and understand where there are pockets of hesitancy to go in there and do the work to get people vaccinated.
Okay, thank you. So we have another question about vaccination. This one is about what to do after you have the vaccine. So the question is, once individuals have the vaccine, what behaviors should they engage in to maximize safety? Can they still pass on the virus? Can they still contract the virus? And then final part, more generally, are we going to see confusion about behaviors as more but not a super majority of citizens are vaccinated?
So Wayne and I could probably answer this. I'll go first. As far as the first part of the question, you definitely have the possibility of still carrying the virus once you're vaccinated. So now I'm going to quote the evidence that's coming out of the initial vaccines that are out now, both Pfizer and Moderna. The efficacy is just remarkable. And I think we all realize that it's 95% effective, but that clearly also recognizes that 5% of the people that are getting the shot aren't developing adequate antibodies. So there's that scenario, which is a small minority of the cases, but at the same time, you can be vaccinated, you can have adequate antibodies and still, what is presumed, carry the virus. You may not have the same amount of viral load, but the possibility exists that you can spread it even once you're vaccinated. So then that being recognized, it is still expected that we should be still practicing the social distancing and wearing of masks for the time being, presumably until we get to a much more controllable disease and maybe that herd immunity level of whatever it is, 70 to 90%. So I think that answers at least the first part of the question. What was the second part of the question?
Can they still pass on the virus, contract it, and do you think people will be confused about behaviors right after they've, some people have the vaccine, but some people don't have the vaccine?
Yeah, and that's one thing that we even went through as a situation in our hospital. Is, remember I said that 80% of our workforce self-selected to get vaccinated. It means 20% is still thinking about it, if you will. And there's some medical scenarios of why people aren't getting it. But the point is, we're not going around saying who's vaccinated, who's not, because that's certainly something that could be controversial. So, I think that, we have to continue to promote that you have to practice the social distancing and wearing of masks for the time being. And we don't want people to let their guard down even once they're vaccinated.
You want to add anything, Wayne?
My only addition to what Dr. Clark has said would be to caution us in moving toward this notion that there is immunity in people who've received the vaccine and therefore they have a passport to travel wherever they want. And I'm fearful of that. I'm fearful of what will happen when we create these immunity passports. And now all of a sudden, if you've been vaccinated, you're welcome to travel to name the country. But yet in many parts of the lower and middle income world, it will be years away before they have mass population distribution of the vaccine. And that, to me, creates more of the inequity the world is experiencing. So that my cautionary tale would be to follow what Dr. Clark said. Yes, if you are vaccinated, there's a plus or minus 5% window that you could get reinfected. Data is now saying that you would have an attenuated infection, so you'd be less likely to transfer. But quite frankly, we're all in this together and we have to think about it as a whole population. So how do we begin to separate, I want my vaccine and I want it now, and remember that there's a global body here that needs to receive the resources?
Okay, I'm looking at the list of questions here. Thank you for that. I think that's important. That's really important information for all of us to hear. There are a couple of questions here about vaccine working. I think you have addressed that. I see Deborah moving around in the Google list. Why do we think that some countries have been so much more effective in managing COVID? Is it leadership, context, citizen belief, some combination? I've been watching Israel, for example, be able to vaccinate large segments of their population, but maybe Dr. Centrone can talk to us a little bit about that.
I think it's a multifactorial response, and I'll be very brief. 1 minute and 7 seconds. I was on a telephone call with a colleague who runs a program in Haiti, and he said, "Hey, oh my goodness, our caseload has been phenomenal. It's just amazing. I mean, in fact, I'm going back and forth between the United States and Haiti, and everything is great there." And I said, "Sorry, Dr. Scanlon, have you looked at the testing data? Do you have any testing data of Haiti? Do you know what testing is available in the country? I mean, is there any prevalence data that you're able?" No. And I said, well, one clear way that we can talk about a lack of infectivity within a country is just not test. So if the numbers aren't there, the numerator and the denominator drive the way that we respond to this. And if we don't have a numerator and we have a suspicious denominator, then we have no public health response. So I think a lot of this is that some countries got out front and got the science down, and they knew what their numerator was and they knew what their denominator was, and they built sound scientific approaches based on those things. And others struggled, and they're still struggling.
That's fascinating. So much to talk about here. Let's see. Long-term consequences of COVID for trust in government. This is a multi-phase question here that somebody has given us. They're interested in understanding, number one, what do we see as the long-term consequences of COVID for trust in government, cooperation for health at the international level, compliance with government requirements, health outcomes, and trust in hospitals and science. So maybe let's break that down into trust in health institutions and cooperation at the international level. How about that? I'm swiping back and forth between the questions and you all. Does anybody want to take a stab at that?
I'll just go real quick on overall trust in government, not necessarily internationally. I think the impact on trust in government is going to be a function of how well we get through the next several months. I mean, if widespread vaccination in the United States is ultimately successful, and we have one of the highest vaccination rates in the world now, if you look at some of the indicators, you could also say we have the highest rate of closing the barn door after the cattle are all out. But the story is fairly positive. So if the narrative ultimately is that the government, particularly under the new administration in Washington, finally got a handle on this and took care of the problem, then I think it could have some short run improvement on trust in government. But if it continues to be slow, if it's perceived to be botched in some way, it'll damage trust in government. But remember, trust in government in the United States is never really been that high to begin with. Now, in other countries, there's different dimensions of trust and different reasons for distrust. But in the United States, it's just kind of some of our data we've been writing about recently, it's just kind of shrugging your shoulders and saying, there goes the government again, kind of mistrust, which, I'm hoping that that an effective response would sort of slow that trend, but time will tell.
Any other comments? I'm looking at. So I'll ask one last question here, because we're right at about time here. Let's see. Do you think that China, being COVID-19's country of origin, and our previous president's remarks about China prior to the outbreak had more to do with skepticism? Maybe that question is a little unclear. Do you think that China, being COVID-19's country of origin, and our previous president's remarks about China prior to the outbreak had more to do with the skepticism seen in the United States than the dismissive remarks made about mask wearing? I guess this question is about politicization of the sort of the emergence of the pandemic and whether or not that had an impact.
I'll just jump real quick and say that this goes right to the kind of work that Kristen and I do. Deborah Stone, who's a well-known political scientist, has written extensively about the way in which stories are depicted, the way in which problems are depicted in public policy. And you often see that people in a public policy controversy or debate will try to shift the causal story about the debate from one of depending on your goals. In the case of the Trump administration, the attempt was to shift the causal story from this is a disease that we could have picked up on if we'd had proper international health surveillance systems, to shift that to who knew that, this would, and it's China's fault and they should have done something about it. And, so it's a combination. It's basically blame shifting is what's going on there. And everybody does it. I mean, it's not unique to the administration. So I think what the administration was simply trying to do is cast it into the realm of sort of the natural disaster, the there for the grace of God go I kind of thing, rather than as the result of sort of bad decisions made by human actors.
Right. I just to piggyback on that a little bit and think about it, like in the context of natural disasters, like Tom said, I definitely think that the previous president's desire to assign blame for the pandemic on China is certainly a political tactic, and it very much falls in line with a whole set of political science scholarship on causal stories behind policy problems. But the other piece of this, to kind of circle back to risk perception, is that the downplay, like if you cast your minds back to what was happening like in February last year, the pandemic or COVID-19 was something that was happening far away and in China. It was not happening here. And, we think about people who live in like hazard prone areas, people who live in New Orleans, or people who live along the Atlantic coast and experience hurricanes all the time. They have this really, really strong desire to diminish their risk perception. It's going to be fine. I'm not going to evacuate unless it's a Category 5 storm because it's so significant, right? Like that would be catastrophic. So I wonder, and I've given this some thought. Like at the time, like a year ago, I wonder if we all weren't engaged in some kind of risk denial or hazard denial. Because it was far away, and we had this causal story that made it that this is something that's happening in China. And meanwhile, the federal government was very slow to even respond and engage all of the existing structures to respond to the emergence of the virus here in the United States. But that the causal story about the virus and then the sort of the risk denial that people were putting into place, and I feel like the two of those went hand in hand.
Fascinating. Well, on that note, we're at past time, and I want to extend my deepest thanks to all of our panelists, Dr. Taylor, Dr. Birkeland, Dr. Centrone, Dr. Clark, for taking time out of your busy and important schedules to spend time with the Southwestern Political Science Association members and our students to talk to us about COVID. Thanks also to the audience members. Some of our parents are on here, some of our college students are on here, and our colleagues are supporting all of this. So we appreciate your coming on and listening to the panel and asking questions. And so thanks everyone. Good night. Have a great weekend. We appreciate you very much, and good luck with your research and your work on the front line, nationally and internationally. We appreciate you.
Thank you very much.
Thank you all.
Be well, everyone.
You too.